consenting to be a part of this program.
Yes, indeed. It's my pleasure and my honor to be presenting to you guys. And I'm happy that my wonderful dear friend, Dr. Masoodi, invited me, and I actually volunteered to be part of this. So I'm really happy to provide whatever little information I can impart. I think the mic just went off for some reason.
Yes, sir.
Did you hear my part?
Yeah, yes.
Okay.
Yeah.
So are we ready to start?
Yeah, sure, sir.
I was waiting. The music was going on, so I wasn't sure whether we need to stop the music and keep it start. Okay. As Dr. Meghna and Dr. Masoodi have so graciously indicated, I am a board-certified anesthesiologist with subspecialty certification in the field of obstetric anesthesia. I'm also board-certified in pain management, pain medicine, and I also practice addiction medicine. But my focus of practice is obstetric anesthesiology. I practice in a pretty busy setting. We have about 8,000 deliveries in a year, so it's a fairly big practice. So we tend to see a wide spectrum of cases because we also manage a high-level, high-risk pregnancy hospital. So we see all kinds of comorbidities there. So I decided to talk about amniotic fluid embolism today for a couple of reasons. One is, of course, it's an interesting topic by itself, but because I know that there are medical students and, of course, postgraduate students from other disciplines, hopefully, and my beloved field of anesthesiology, hopefully some people from there as well. So I decided to choose this topic because the management of amniotic fluid embolism, well, the diagnostic process and the management gives us a segue to talk about some other aspects of managing these patients, which are common with other critical situations that can evolve in either an ICU setting or on a floor. So, for example, managing a massive hemorrhage that happens as part of the AFE is similar in many respects to what you get with amniotic fluid embolism. So it'll give a review of the managing of massive hemorrhage with AFE, but also that applies equally to others. So for gastroenterologists there, I'm sure you see your liver disease patients having massive hemorrhages sometimes, and this may apply to those situations as well. So without further ado, let's get started. We're going to start with a little patient vignette, and that sort of gives us a segue into starting the topic. My disclaimers: I have no financial disclosure, sadly, and I will be talking about some off-label medication use. So starting with the patient vignette, we have a healthy 33-year-old female with G2P1 at 38 weeks gestational age. She has a history of one previous cesarean delivery because of a breech presentation. And the reason that's important is that with the recognition of the fact that the rate of cesarean sections is very high pretty much throughout the world, and especially in developing countries, if there has been a previous breech delivery, so the C-section was because of breech presentation, then they are allowed to have a trial of labor after that cesarean section. In other words, in the next pregnancy, they can opt to go for a normal vaginal delivery. And this, so she was allowed to undergo a trial of labor after a cesarean known as TOLAC. While she was in labor, and because she was in labor and she was hurting, she requested an epidural, and she had a well-functioning labor epidural. And that's one of the advantages of placing these epidurals. And for those of you that practice on the anesthesia side, and those of you that practice on the OBGYN side, I would take this moment to really urge you guys to focus on getting these epidurals early, because it not only provides pain relief to the mom, and so it's a humane thing to do. It's something that they can choose, to take care of, but also it provides the ability to give immediate anesthesia. So you can immediately top it up with some lidocaine or some chloroprocaine, some fast-acting local anesthetic that will give you a surgical level within 3 to 5 minutes many times. And and at the same time, it avoids the general anesthesia, which can be problematic sometimes in pregnant, especially moms that have been laboring for a long time. In any case, she had a well-functioning labor epidural and was cardiovascularly stable, even though she had some preeclampsia with this pregnancy, and preeclampsia with severe features. So intrapartum cesarean delivery was called because of a failure to progress. So her labor wasn't progressing like they thought it should, and her preeclampsia was also a comorbidity, and her blood pressures were quite high, but she had been relatively cardiovascularly stable otherwise. So in short, she was taken for a C-section. Her epidural was bolused, and she was taken to the OR for a cesarean delivery. In the OR, the cesarean delivery proceeded uneventfully. A healthy fetus was delivered. Immediately following the delivery, the patient started complaining of an odd sensation of something not being right. And when we go to the diagnostic criteria, and when you read the literature on ASPE, you will notice that the patient, what is called a premonition. In other words, the patient saying that, oh, something is not right, something is very wrong. I feel like something bad is going to happen. And so this is called, a feeling of impending doom. So you'll have this kind of premonition by the patient. So the patient complained of this odd sensation along with the shortness of breath. She then proceeded on to have a grand mal seizure and hemodynamic deterioration, which was significant enough to require induction of general anesthesia. So we induced general anesthesia primarily to control her airway, but also to facilitate the diagnostic process and the management process so that we weren't distracted by trying to keep her stats up and trying to prevent aspiration and those kinds of things. So immediate general anesthesia was induced, and the airway was secured. And meanwhile, the obstetrician started saying that she's having diffuse oozing and poor hemostasis on the field. So they were having trouble controlling her bleeding. At this point, we will stop the vignette. And of course, you can ask yourselves the question, what would be the possible causes for this to happen? Why did this happen? In other words, if you didn't know that I had already told you that we're talking about AFE, if you did not know that, what would lead you to the proper diagnosis in this case? And what would be your differential diagnosis? So we'll talk about all of those things. So we'll stop the vignette here, and we'll kind of shift gears and go to the introduction of what it is and how we go through the process of diagnosing, managing these patients, and we'll talk about some upcoming strategies and things like that. So the amniotic fluid embolism, or AFE, has essentially been a diagnosis of exclusion. In other words, people have not had any particular biomarkers or particular pointers in saying, oh, this is a cardinal sign, or this is the only feature that happens in AFE. So traditionally, it has been a diagnosis of exclusion. Even in the 1920s, when it was described, it was a post-mortem diagnosis, essentially. When they did a post-mortem on those ladies, they found amniotic material in their lungs. So they assumed that, oh, it's an embolus from the amniotic material, and therefore it's amniotic fluid embolism. We now know that it's not just an embolism situation. In other words, it's not a mechanical obstruction only. It may be something much more complicated than that, and indeed is. And therefore, Clark et al. Later on decided that they actually suggested, I should say, not decided, they suggested that it should be called the anaphylactoid syndrome of pregnancy as opposed to the AFE. Which makes sense that it's an anaphylaxis-like reaction, but it is non-IgE mediated, and so they thought that, well, it could be like an anaphylactoid syndrome of pregnancy. the name actually never caught on, so it's more of a niche description. In other words, people that are in the field would possibly know what anaphylactoid syndrome of pregnancy is, but if you talk to anybody about amniotic fluid embolism or AFE, pretty much anybody will know what you're talking about. So the possible cause has been some kind of a breakdown in the placental barrier. Again, we do not know the real cause. We do not know the exact pathogenesis, but we know that there's some kind of a breakdown in the placental barrier, and the amniotic fluid enters the bloodstream, which then causes the resultant exposure, the resultant train of events in the mom's system. The incidence of AFE is somewhere around 1.9 cases per 100,000 babies. It's difficult to know the two numbers because of reporting differences. In other words, different countries have different reporting guidelines. So some people over-report, some people under-report, because the diagnostic criteria are not set in stone. So it's hard to know what the exact incidence is. Nevertheless, the numbers that are being quoted are about 1.9 to 6.1 cases per 100,000 deliveries. The AFE-related morbidity and mortality.
Sorry for the interruption. Dr. Sorry for the interruption.
No worries.
Just hold on 5 minutes because we're getting some technical difficulties.
Okay.
I'll put it off. I'll start again. Please,
Sure.
everybody, listen. Sorry.
Shimar. Madam. Madam. എന്നെ തന്നെ പുറത്താക്കിയോ അവര്? ആണോ?
Please keep off the videos. Sir, video off कर रखा है.
Tell me when to start again.
Yeah, sure, sir, sure. Sorry to interrupt.
No worries at all. I'm right here, no worries.
Yeah, sure. Thank you very much. Please keep off the videos. It interrupts. Well, some participants from the Please keep off the video, sir. People are coming. Yeah. Yes, sir. You can start now, sir. I will be admitting them.
Okay. All right. Sounds good.
A lot of people have come.
Sure. So, coming to the AFE-related morbidity and mortality, again, let me preface this by saying that, remember, the reporting of this is somewhat murky in the sense that the diagnostic criteria are not set. So consequently, when the death certificate is written, so the cause of death may be written as something else, and in reality they may have had AFE, or the cause of death may be written as AFE, and in reality they died of something else like anaphylaxis or some other problem. In any case, the AFE-related mortality is estimated to be between 5 and 15% of all maternal deaths. The case fatality rate is somewhere around 11 to 80%, which means for especially the students and those that don't understand case fatality rate, case fatality, and this is important actually in the current COVID crisis context as well. Case fatality is the number of confirmed cases, however many cases there are, how many of those patients die. So in other words, out of the, say, 10,000 people that have the confirmed condition, whether it's an infection or whether it's AFE or anything, what percent of these people die? So the case fatality rate for this particular condition, i.e. AFE, has been said to be between 11 to 80%, which is pretty high. I mean, if you think about it, if you say that, 15 to 80% of people that have this problem die, that's a humongous number. The perinatal mortality rates are also quite high, between 7 to 44%. The people that do survive, they may have persistent neurological impairment in between 6 to 60% of the women. Significant morbidity also happens in the infant survivors, including cerebral palsy, ischemic encephalopathy. So anything that results from a lack of adequate perfusion for a long time, those are the conditions that are going to show up after this if they survive. What are the risk factors for this particular condition? There are some maternal risk factors, there are fetal risk factors, and there are procedural risk factors. So the maternal risk factors would be obesity, advanced maternal age, polyhydramnios, placental anomalies like placenta previa, abruptio placentae, placenta accreta, increta, percreta, all of those, preeclampsia, eclampsia. The fetal risk factors, one of the fetal risk factors has been found to be a higher incidence of AFE with male fetuses and with Rh isoimmunization. The procedural factors which are associated with this include cesarean sections. So if a mom delivers by cesarean section, which was the case with our patient in the vignette, that's where it happens. Instrumental vaginal delivery, such as forceps and vacuum. D&E procedures, dilatation evacuation procedures, induced augmented labor. So in other words, not spontaneously occurring labor, but augmented or induced labor, and cervical lacerations from any reason. So those are all risk factors for getting AFE. What is the etiology and pathogenesis? We already said that there's some kind of a breakdown in the placental barrier that exposes the maternal side of the circulation to fetal side, fetal contents or antigens. So breakdown of the placental barrier, which then leads to exposure of maternal circulation to fetal antigens, and there's the resultant anaphylactoid maternal reaction. The flow chart, shows you kind of a step-by-step approach to how they've thought this happens. Number one, the initiating cause is exposure to amniotic fluid or fetal antigens. That then leads to this kind of a four-pronged insult. There's an immunological release of mediators, there's mechanical obstruction, there is activation of the complement system, and simultaneously there's also activation of the coagulation system. As to how each one of these happens, there's a huge body of literature on each of those things, and I think it would take us a much longer time to go through all of those pathophysiology nitty-gritties, but suffice it to say that these are the four big things that happen. Now, on the left-hand side, three of those things, the mechanical obstruction combined with the immunological release of mediators and the activation of the complement system, has direct cardiopulmonary effects. And in the form of initially, the first thing that happens is severe pulmonary vasoconstriction, which then causes acute pulmonary hypertension, which then causes strain on the right heart, because it's a back pressure on the right heart. The right side of the heart can't pump into the lungs because the pressure inside is so high. If it can't pump in there, that means you're not getting an adequate perfusion there. And so you can have hypoxia because you're also having shunting because of the vasoconstriction. And so that causes hypoxia and right ventricular failure, which then has an effect on the left side, causing left ventricular failure. And if you have left ventricular failure, you can obviously assume safely that they're not going to have adequate perfusion of the rest of the body, which then causes the problems with coma, seizures, residual deficits. If they survive, they can, the lung effects will also have an effect on the development of lung injury, acute respiratory distress syndrome, and then of course all the other organs that are affected, for example, the kidneys.
Sorry to interrupt, Dr. Yunus. Can you check the slides? I'm able to see some of the messaging that slides are not seen.
The slides?
Yeah, I'm able to see, but I got messages that slides are not seen.
Okay. I am able to see my slides properly here.
They are able to listen you, they are able to see you, but
hang on a second. Are they? It says that I'm sharing it says meet.google.com is sharing your screen. So I'm not sure what they're doing at their end.
Just a minute. Pin on the slides. Now they are able to see the slides.
Okay, good. Okay, perfect. Wonderful. I'm glad that worked out. So they can have, the pulmonary effects eventually leads to the cardiopulmonary collapse, and sadly, it will result in a mortal event in many of these moms. The coagulation system activation on the right-hand side of this cascade, there's activation of the coagulation system, which then leads to a consumption coagulopathy, and therefore that will lead to a massive hemorrhage. causing, of course, that needs to be corrected, and obviously that can be a fatal outcome as well if it is left uncorrected. And we'll get to that as well in the next few slides. Presentation, again, tie this slide to what we talked about in our patient vignette. The patient has this feeling of impending doom, that something is not right, they are going to die, or something bad is going to happen to them. Immediately following, they may have some chest pain, which is inconsistent, but it can or cannot be present. But if it is, that may tie into this as well. Immediately followed by sudden or unexplained cardiovascular deterioration or collapse. Then they may have altered neurological status. Either they just pass out or they have a seizure. So I've had about, in our practice, I know of about 3 or 4 of these patients that we've had exposure to. Thankfully, most of them survived. And we did have one lady pass away. And the consistent story that I've gotten from all of the anesthesiologists that were present in those cases and the ones I was physically myself involved in, the patient suddenly says, it seems like they almost like stretch their arms to, like they do this kind of a deal where they stretch their arms to both sides as if they're, taking a deep stretch. And next they're talking to their, because we have the family member present in the OR for C-sections right next to them. So they're typically talking to them. Suddenly they have this feeling, they stretch their arms and boom, they're out. Next thing you know, they're unconscious, they're not unresponsive, you do not know what happened. And you start noticing desaturation, you start noticing cardiovascular deterioration, and you know that something is not right and you better act fast. And of course, continuing, they have a coagulopathy, which more than likely the obstetrician will first tell you, or if it's a labor patient, then of course the nurses will say she's starting to bleed for some reason, and you may be called in for an urgent delivery because of a bleeding issue. Because there is some literature that says that up to the UK has a very strong and a robust reporting system compared to many other developed countries or developing countries. So they have a very strong and robust maternal surveillance system. And in that they said roughly about 40% present with a coagulopathy during labor, and as opposed to just a cardiovascular collapse. In any case, coagulopathy is part of the spectrum, as is respiratory compromise. As you notice that our patient started having desaturation, so we immediately intubated her and put her on a ventilator. So they can have dyspnea, cyanosis as a result of this. Then how do we diagnose these patients? Now, again, I'm going to repeat at the risk of sounding redundant, there are no universally accepted diagnostic criteria which have been found to be true in every situation in every country. So these criteria are somewhat different. But in any case, the Society for Maternal Fetal Medicine, SMFM, which is a sister organization of the ACOG, American College of OBGYN, so SMFM and the AFE working group, which is sort of a working group of these people that work on the on how to manage, how to have the best outcomes from the AFE situation. So the AFE working group and SMFM came up with these diagnostic criteria, which are as follows. Number 1, sudden onset of cardiorespiratory arrest or hypotension, which is traditionally accepted to be systolic BP of less than 90, with evidence of respiratory compromise, traditionally accepted to be oxygen saturation less than 90%. Clinical onset either during labor or within 30 minutes of placental delivery. It has been reported that this can happen up to 48 hours after delivery. There are some isolated case reports of it happening as late as 24 or 48 hours after delivery. But for the purpose of the diagnostic criteria, they have said that it should happen either during labor or within 30 minutes of delivery. There also has to be, ideally, absence of fever during labor. And the reason for that is because then if you have high fever, you would think that maybe they were septic and they went into a septic shock. So that kind of muddies the picture, and therefore may not be a specific diagnostic criterion that you would be able to use. So they added absence of fever during labor. Continuing with that, there's documentation of overt DIC using the scoring system of ISTH, which is the International Society of Thrombosis and Hemostasis, as modified for pregnancy. It has three different things that they basically score on a 0 to 2 point scoring system. So platelet count more than 100,000, you get 0 points. Less than 100,000, you get 1 point. Less than 50,000, you get 2 points. Prolonged PT or INR with a less than 25% increase, you have 0 points. 25 to 50% increase, you get 1 point. And if your INR or PT is prolonged more than 50%, then you get 2 points. Same thing with fibrinogen. If your fibrinogen level is more than 200 milligrams per deciliter, you get 0 points. And if you have less than 200 milligrams per deciliter, you get 1 point. Score of more than 3 is compatible with overt DIC. So this, you can pretty much, the one thing that you would be, those of you that do not work in the obstetric field or in the anesthesia field, if you have other, say, trauma or a massive hemorrhage from a liver disease or some other issue, then sometimes the fibrinogen level might throw you off, because in a normal patient, in a non-pregnant patient, a level of 200, the amount, and we'll talk about this later as well, I'll show you a slide on this, the amount of circulating fibrinogen in a pregnant lady is roughly twice what it is in a non-pregnant state. So consequently, in a non-pregnant lady, if you see the fibrinogen less than 200, you wouldn't be that worried about it. Say if it was 150, 160, you would be like, it's okay, it's not that bad. In a pregnant lady, if you see a fibrinogen less than 200, the ISTH already gave it 1 point. So that ties in with the diagnosis of the DIC. Now, this coagulopathy must be detected before you have massively transfused them or they were already in septic shock before. So the coagulopathy has to be detected prior to that happening to avoid the confounding factors of shock-related consumptive coagulopathy or dilutional coagulopathy that happens with massive hemorrhage. This is a these early warning scores have been used for a long time in trauma, in other critical situations, to sort of give the whole team that is caring for these patients, for any patient. So if that, it gives them an early warning system. It's like having an early warning system where something like a red flag pops up or a yellow flag pops up or a white flag pops up. And if you have too many of the yellow flags or too many of the red flags, then that provides you the impetus to go for the next step in that algorithm. So if you look at, I'm not going to go through each of these numbers, but suffice it to say, on the left-hand side, you have the physiological parameters. Then for each parameter, you have a normal value, you have the yellow alert, and then you have the red alert. So you can see that for respiratory rate, it's 10 to 20, 20 to 30, and then either less than 10 or more than 30. And we'll come to the next slide. I'm sure you'll have time to this. Will be hopefully recorded, so you'll have access to this slide. So this particular warning system was then adapted to use for moms during labor and delivery process, so that when they are caring for these in the antepartum time or during labor or postpartum, then if any of these things, then that can lead to the appropriate action by the caring team. So let me go to the next slide and show you how you proceed with this. So you complete a full set of Muse observations, Muse as in maternal early warning score observations, or maternal early warning score, Muse. So if you have one yellow alert, you repeat the observation in 30 minutes. In other words, if you have one of those, going back to this, so if you have one of those yellow alerts, meaning their blood pressure is either too high, too low, their breaths are greater than 20, their heart rate's above 100 or less than 50, then if you have one yellow alert, then you reassess in 30 minutes to see what's going on with the mom. And if you have 2 yellow alerts or 1 red alert, meaning you have another yellow alert in 30 minutes, or you have 1 red alert at the beginning, or next time at 30 minutes you have the red alert, you call the obstetrician and tell them that, hey, this is going on. What do you want to do? Is there something specific you want me to address? And so then that meaning the nurse would do this technically on the floor that we have. Obviously, if you have residents, students, they would be notified, and they can then start the train of the diagnostic process and throw it up the chain of command to the senior resident and and then the consultant and all of that stuff. I would argue that even though it says call the obstetrician, as anesthesiologists, we are essentially the intensivists for labor and delivery. There is not a intensive care specialist sitting there right on the L&D floor. We are, as the anesthesiologists, we are the intensivists for our OB colleagues most of the time. And they rely on us to bring our expertise to bear on this field. And so I would argue that at least in our hospitals, our labor and delivery team will actively seek out the anesthesia team and say, hey, we've had this, the mom's blood pressure is this, the mom's heart rate is this. I've called the OB, but I want you to be aware that this is going on. So then that gives us a kind of a pointer. We keep our ears out and eyes open that, hey, something is going on, something bad might happen. So we should probably be heading in that direction to try and assess what's going on. Obviously, step 3 would be if you have more than 2 yellow alerts or 2 or more red alerts, there should be immediate review by obstetrician, and again, most likely the anesthesiologist as well, and keep repeating the observations or change over to continuous monitoring of both the fetus and the mom, depending on where the mom is at that moment in time. This is sort of again, a slide for you guys to review at your leisure. This is the pre-hospital trauma life support and advanced trauma life support classification of shock. And basically it has the physiologic parameters on the left side, as in blood loss, heart rate, ventilatory rate, systolic blood pressure, and urine output. And then it talks about what happens in each of those classes, class 1 through class 4. What I want you to kind of take a look at is class 2. In other words, you can lose up to 15 to 30% of your blood volume before you see anything, and their systolic blood pressure in class 2 is normal. So think about that. 30% of your blood volume is gone, and your systolic blood pressure may still be normal. So don't be fooled by just, that, oh, her systolic pressure is okay, she's stable, she's fine, there's nothing going on. Urine output is still 20 to 30 ml per hour, I'm good, there's nothing major going on. So I should be okay. And the heart rate is minimally increased, say more than 100. So it's maybe 105, 110, something like that. So you sort of have some idea, but it's not horrible. So especially this is true with pregnant moms. I would again urge all of you, those of you that are students, those of you that work in OB, but may not be dealing with critical situations. And of course, our anesthesia colleagues are always up to the mark on managing critical situations. But be vigilant, especially in pregnant moms. They can handle a lot because they have an expanded plasma volume as a normal consequence of pregnancy. So you may think, oh, she's doing fine, she's stable. And so it's almost like they're going along in this river and there's a cliff coming. So you're normal, or close to normal, and then suddenly they fall off the cliff, and next thing you know, they're coding and you don't know what's going on. So be careful, be vigilant. That's the point of this particular slide, that, up to 30% of blood loss and you still have semi-normal physiologic parameters. Now, there has been some criticism of this PHTS ATLS classification of shock as to how important, how reliable it is, and whether we should rely on it or should we rely on the shock index and things like that. But that would be a different discussion altogether. In other words, be vigilant. This is a sort of kind of a segue on the side for those that are interested. This is what is called the ROSE, i.e. rapid obstetric screening echocardiography. It's a diagnostic modality. It's also a modality to assess response to therapy, but it follows an ABCDEF algorithm where it is acceptable and applicable. It's done at the bedside, typically on the left-hand side of the patient, because you want a parasternal and apical view. So it's an echo, basically, that you're doing transthoracic echo. It helps you many times in the diagnosis, but also in assessing the response to therapy. If there has been an embolism, you can assess the right heart function and the size. As we talked about, the first thing that happens is severe pulmonary hypertension, followed by the right heart failure. And so it allows that. It also allows for fetal heart rate assessment. It is important to remember, you cannot stop the care. In other words, if you're resuscitating the patient, you don't stop that to do this. This is done only if you have the manpower available and the technical expertise available for somebody to be doing this while you're dealing with the critical situation. So you don't want to stop caring to do this fancy thing. So that's just something for your information. How do we manage these patients? And what did we do with our patient? We'll talk about that as well. So the important thing to remember is that we need to differentiate between medical and obstetric disorders with similar presentations. So you can have hypertension, which our mom that we talked about did, the proteinuria, which is part of the eclampsia spectrum. They have proteinuria. They have rising creatinine, they may have thrombocytopenia, and they may have seizures. So obviously Our Lady had a seizure. So how do we deal with this, and what do we keep in mind? The clinical syndromes, as we talked about, number one, for example, if you have a seizure, the seizure could be from the eclampsia. So this mom had severe preeclampsia. If it worsened, she may progress on to eclampsia and get a seizure. It could also be from epilepsy. So you have to rule out, oh, is she epileptic? Does her history say she's epileptic? If she is this neurological deterioration because of her pre-existing medical condition? Or is this a result of the eclampsia? Or is this a result of some other embolic phenomena like the AFE? If they go into a coma, again, it could be a post-ictal kind of state during eclampsia, which has happened, which we've all seen many times. Those of that deal with pregnant moms or obviously with other the neurology colleagues, they've seen these seizure patients, and of course they're post-ictal. So it could be a post-ictal state from that, or it could also be a cerebral venous sinus thrombosis, which is common in pregnant ladies because of their hypercoagulable state. It could also be an intracranial hemorrhage from elevated blood pressure. So you have to rule out is it an obstetric cause or is it a medical cause? Same thing with pulmonary edema. Is it an AFE or is it mitral valve disease? Same thing with hypertension. Is it preeclampsia by itself, or is there an underlying element of glomerulonephritis or some other reason that is causing the hypertension? Same thing with proteinuria, thrombocytopenia, and same thing with hypotension. So Our Lady in the vignette had hypotension, she had the seizure, she had respiratory difficulty. So it is important to remember that this thing deteriorates very rapidly. You do not have the luxury of time to sit and order fancy testing while you are waiting for the thing to resolve. You have to act, and you have to act quick and aggressively. And so you treat it quickly as best as you can with low risk, high reward interventions, so that you're already in the management process as you're doing the differential diagnosis process. So you can't stop the process of caring for these moms and taking care of them and stabilizing them while you're thinking in your mind what it could be. So as you're narrowing down the diagnosis, so you're doing an assessment, clinical assessment. In other words, she had sudden chest pain or feeling of impending doom. She suddenly had a seizure. She had sudden hypoxia. She had, a sudden hemodynamic deterioration, and the pressure is now 70/40. So if it happens, and it happened immediately following delivery, there are not that many things that will cause that level of rapid deterioration in that clinical situation. Obviously, if it's the floor, it's a non-pregnant patient or patient in the first trimester of pregnancy, and she has some other coexisting medical comorbidities, then you can take the time and you want to make sure that, okay, what else could be going on in that. In this particular situation, it was sort of pretty clear that something really dramatic or drastic had happened. Either she had a PE, but typically, again, seizures will not happen in a PE unless they become hypoxic first, and then they stop. Of course, the next thing that happens is they have severe cardiovascular collapse, and then they just kind of pass out, and then you have to, they're unconscious. But having a seizure, at the same time, then this feeling of impending doom, you have to quickly jump on board and start managing these patients. So I'm going to talk about this, and again, like I said, we did talk about that we would be, mentioning some off-label medication use. The FDA has not approved the use of atropine, ondansetron, and ketorolac for the treatment of this particular condition as a regimen. In other words, this is just something that was mentioned. A mechanistic explanation was sought, and this was mentioned by Barb Leighton and Dr. Rizai, and some other. There are case reports in the literature that have been mentioned by using this AOK protocol. So what this AOK protocol is you give atropine, ondansetron, and ketorolac, and each of these has a reason why it's given. Atropine obviously is a vagolytic. Ondansetron is a 5-HT3, and ketorolac is, of course, an NSAID. So they are given essentially for their antithromboxane activity, which would be the ketorolac. The atropine is given for its vagolytic activity, and the ondansetron is given for its anti-serotonergic activity. And all of these three mechanisms, i.e., a strong vagal tone causing a deterioration of the cardiovascular status, the thromboxanes causing a release of the mediators, other mediators, and causing mast cell degranulation, and which incidentally is another thing that some people check is serum tryptase levels, because in fatal AFEs, serum tryptase levels are quite high. So again, lending some credence to the fact it's more of an anaphylactoid type reaction. So this AOK protocol is a low-risk, high-reward intervention. In other words, if she didn't have an AFE, if there was some other reason, you're not going to do much damage by doing this intervention. You give the atropine, their heart rate might jump up a little bit. If they don't have the AFE, the ondansetron, they may have some issue, but typically within 4 to 8 milligrams of ondansetron, you really shouldn't have much problems at all, unless they have a congenitally prolonged QT interval, in which case you would obviously want to be a little bit more careful. But for the most part, these interventions are routine. We do them pretty much every day. Every mom gets ondansetron. All of our C-section ladies get ketorolac afterwards. So atropine is a little bit more unusual to use in these, but it's been used for decades. It has a good safety record. So it's a low risk, high reward intervention that you can do. There have been case reports that it has caused a nice reversal of this situation. So you quickly, it's at hand in the room. Hopefully you can quickly give it, and you don't have to stop doing what you're doing to do this to do this intervention. So again, we did the AOK protocol, and in the ones I was involved, I quickly, as soon as they first had the symptoms, I quickly did the AOK protocol. We intubated them, and thankfully, like I said, the ones I was involved in, they survived and did well. You do need the respiratory support, as we said. There is severe pulmonary vasoconstriction and VQ mismatch, and it requires intubation and ventilation. You want to manage the ventilation, and our anesthesia colleagues, of course, all know, the strategies that you should use in these patients. You do not want to use high airway pressures. You want to, you possibly use pressure support ventilation as opposed to volume control. So you want to manage the airway pressures properly. And there are some reports that the initial pulmonary vasoconstriction and VQ mismatch has been treated successfully with inhaled nitric oxide and aerosolized prostacyclin. I myself have not used this for this situation, but there are reports of having, these things having been used successfully. Now, coming on to the hemorrhage management. These patients will almost, if it is a true AFE, they will almost universally have uterine atony. You have to manage it with, just like you would manage any uterine atony. And you manage it with uterotonics like oxytocin, carboprost, methyl ergonovine, which is methergine, and misoprostol, which is under the trade name here in US, it's marketed as Cytotec. So all of these are used sequentially to help with the uterine tone so that you don't keep on losing blood, because in addition to the coagulopathy, now you're dealing with a uterus that is limp and not contracted, then you're losing a boatload of blood just by that. If the uterotonics don't work, then you may require a surgical intervention, such as a Bakri balloon, which is essentially a big Foley catheter that's inserted into the uterus and then inflated. The balloon is inflated, the bulb is inflated, and it tamponades the uterus from the inside. So it's called a Bakri balloon. Hopefully our OB colleagues, if there's any on this call, they would know what the Bakri balloon is. The surgeons among us, they are the obstetricians, they can place what is called a B-Lynch suture, which basically is 2 sutures around the uterus, very tight, to basically physically, mechanically contract the uterus. And either concurrently with this, or in lieu of this, if this does not work, then some people, then obviously go for uterine artery ligation, embolization. There's also embolization of the internal iliacs. If you have access to the interventional radiologist, they can come into the OR and embolize the uterine artery, the internal iliacs, to help with bleeding. Finally, if nothing else helps, obviously you want to proceed quickly with hysterectomy. You don't want to waste time. A delay in a decision for hysterectomy sometimes will cause significant morbidity and indeed sometimes mortality. So you don't want to wait too long to do that. So if it has been decided that the uterotonics and the Bakri balloon and the B-Lynch and none of that is working, then you don't want to wait too long. I'll take a moment to talk about REBOA, which is the resuscitative endovascular balloon occlusion of the aorta. This is something our trauma colleagues have used for a while. And basically what it is that, and I'll show you the slide here coming up next. This is what a REBOA is. Again, resuscitative endovascular balloon occlusion of the aorta. So basically you are physically occluding the aorta with an inflated balloon. And what that does is it stops the blood flow to the lower half of the, wherever past the arch of the aorta. So as you can see, there is zone 1, zone 2, zone 3. And you want to place the balloon in zone 1 where it causes the maximal physiologic changes. Typically in a hospital, there is a few specialists that are, they can be maternal fetal medicine specialists, or they can be trauma surgeon specialists, or obviously cardiologists, people that cannulate the aorta. And so these people are certified in placing the REBOA. But if you have access to this, it would be nice, and you can look at it later at your leisure. We don't want to spend a lot of time on this, but it is a potentially life-saving intervention that may help. What else do we need to do? We also want to, place some invasive lines in the form of an arterial line and a central line, because those can assist with both the transfusion and also with labs. Because as we said, we do need to do a goal-directed management of the hemodynamics. So you will need labs to be able to do that. You draw a CBC, which will give you the hemoglobin hematocrit. You'll draw a CMP, which will give you access to their electrolytes, but also your kidney functions and liver functions. And then, of course, the DIC profile, which will tell you about fibrinogen and the INR, and especially in pregnant moms. Like I said, again, let me stress, fibrinogen, 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 very important. The ABG, of course, will tell you about the acid-base status, and of course, temperature support in the form of normothermia. This is something that is frequently overlooked, even though, as anesthesiologists, we are very cognizant of temperature issues, but multiples of studies have shown that with hypothermia, you get coagulation problems and you get acidosis, which in turn will reduce your effectiveness of using pressors. So if you're trying to give them a levofed infusion, norepinephrine infusion to manage their hemodynamics, and they're not responding, you may want to check that, if they're too cold. So you want to maintain normothermia to optimize your response to vasopressors, because acidosis will decrease your response to them. And this is true for any massively bleeding patient. It is not just AFE. It is any critical situation where you're losing the patient. You want to make sure that the temperature is okay. Hemodynamic support, again, the large bore IV access above the diaphragm. So you want to try and put either 216 gauge IVs. If you don't have the ability or the time or the expertise to place a central line, don't waste time with it. Do not take time out from resuscitation and stabilizing the patient to do fancy stuff while you're forgetting the basic stuff, which is, have large bore IV access. Even if it's 2 peripheral IVs, at least get started with that. Don't wait on giving the blood products that are necessary to reverse the coagulopathy because you're waiting to place a central line. So if you have the ability, do it. If not, continue with peripheral IV access, place an arterial line. Again, hopefully you will not stop resuscitation to be able to do that. You want to make sure that somebody else is helping you. Call for help. This is not the time to go it alone. Call for help. Large bore IV access using 216 gauge IVs, or if you don't have that, 116 and 118, or obviously a central line with a cordis through which you can both, you can have a double lumen or a triple lumen. Ideally a cordis, which will give you massive transfusion, but also with a side port, so you can then transfuse, get some medications if needed. Then you have a massive transfusion protocol initiated on the unit. So in pretty much all of the hospitals that care for critical level of care for the moms in the US have, and in most developed countries now have this protocol called the MTP, or the Massive Transfusion Protocol, or MOH, Massive Obstetric Hemorrhage Protocol. And typically it's a big chart. It's stuck right on the wall in the OR for everybody to see. And so that everybody can look at it and you don't have to make any guesses. So it's like a cognitive aid for everybody. And what it tells you is that, hey, you have this, if you've given 4 units, what do you need to do next? If you've given this, what do you need to do next? And so massive transfusion protocol is initiated. Then you start using vasopressors. Again, this is true for pretty much anything. If you have a massive bleed for whatever reason, you ought to have a massive transfusion protocol, whether it's the gastroenterology suite where you do your endos and you suddenly have a massive variceal bleed and you can't gain control of it. You don't want to be stuck there, just because you don't have access to this. You want to have some protocol in place so that the machinery is set in motion quickly, so that the blood bank knows what they need to send you quickly. If you say, I have a stage 3 hemorrhage, they should know what to send you. You can't be waiting to tell them step by step, oh, I need 2 units of PRBCs, I need 1 unit of packed cell, FFP, I need 1 platelet. They should know that if you call for a stage 3, the entire cooler, which has 4 units of packed cells, 4 units of FFP, 1 10-pack of platelets or 6-pack of platelets, and some cryo right there. So you don't need to wait for that. You can't be waiting on this situation. Then if the vasopressors and everything else you're doing is not helping much, you may obviously need to do mechanical compression, mechanical support in the form of chest compressions. Remember to put a board under their back, a firm surface to provide good support under the back while you're doing chest compressions. Again, basic stuff for any code situation or any critically ill situation. You may need to place an IABP, intra-arterial balloon pump, if you have the expertise and the personnel that can do that, and you're not able to, gain control of their, using pressors, gain control of their hemodynamics, then you use IABP. They may need to be, as a last resort, you may need to place them on ECMO, but hopefully it won't come to that. This is what our massive transfusion protocol looks like. This is what hangs up in our OR. I'm not going to go through this. Obviously, it's a very busy slide, so I won't go through all of it. You can look on briefly that it's stage 1, stage 2, stage 3. And so with stage 3, you already know what you're giving. So that's what the massive transfusion protocol looks like. So we call the blood bank and we say, okay, stage 3 in progress, and they know what to send us. There's a runner, there's a pharmacist that's available to help if needed. So all of those things come into action. You need additional nursing staff. So all of that comes into action with any massive transfusion situation, not just AFE, any massive bleeding situation. Again, this is the slide I was telling you earlier. This shows you some of the changes that are in the that happen in moms during pregnancy compared to the non-pregnant state. You can see that the platelet count is somewhat lower in pregnant moms. The fibrinogen is high. Again, look at the caption. Total amount circulating fibrinogen is approximately twice that in the non-pregnant state. And all the others, I'm sure you're aware of what the changes in the hemostasis factors are in pregnancy. Again, continuing with our massive hemorrhage management, because this applies to many different situations. Again, the management has to be goal directed. You're not just giving something for the sake of giving it. You ought to have an endpoint in mind. In other words, the patient's blood pressure should stabilize. Their bleeding on the surgical site should be better, and their obviously oxygenation status should be better. When you check their labs, their hemoglobin should hopefully be 8 or above. Their fibrinogen should be at least about 150 to 200. In the pregnant mom, it should be about 200. Hopefully, you can keep it about 200. But bottom line, that's what you want. So you want to have a goal-directed management, not just giving something for the sake of giving it. Typically speaking, the ratios of things that you're giving, the packed red cells to FFP to platelet ratio is typically 1:1 or even 1:1.5. In other words, you're giving more FFP than you're giving PRBCs, depending on what the situation is. So because you want to give them the coagulation factors that are present in the FFP. And remember, the FFP does not have a huge amount of fibrinogen. And so you want to use either cryoprecipitate or fibrinogen concentrate. If you don't have access to a cryoprecipitate, then these days the FDA, at least in the US, has approved a lyophilized fibrinogen concentrate known as Riastap. It's available for use in those situations where you don't have access to cryo, or you don't want to use a huge volume, because the cryoprecipitate comes as a bag, just like a platelet bag. So you want to make sure that, if you're not wanting to give them too much volume because your echo has indicated they are in heart failure, then you may not want to overload them with volume. So you treat them with, you may give them fibrinogen concentrate. You want to use some sort of testing to guide you, meaning the coagulation testing. And if you have access, again, to viscoelastic testing, like ROTEM or TEG, these are rotational, the ROTEM stands for rotational thromboelastometry, and TEG stands for thromboelastograph. And basically, it measures the formation of the blood clot right from the initiation phase all the way up to the formation and the fibrinolysis phase. So it kind of it measures the entire spectrum of the clotting process. And it's obviously this is a separate discussion as to the details of how these things work. But if you have access to some sort of testing to guide that, that would be nice. You want to use, in this situation particularly, in pregnant ladies in massive obstetric hemorrhage, you want to use tranexamic acid early. It's an antifibrinolytic drug, and you want to use it early. For those of us that are in obstetric anesthesia, those colleagues or those that have interest in obstetrics or obstetric anesthesia, hopefully will have read about the WOMAN trial, WOMAN, WOMAN trial, which showed a significant benefit of this tranexamic acid. And in fact, a lot of the benefit, the highest benefit, was in the less resourced countries where you don't have access to the top level resources. So you should use tranexamic acid. In our patients in massive obstetric hemorrhage, this is one of our first interventions that we do. And I'm talking about non-AFE situations as well. Factor 7A and heparin have been postulated by some people. In other situations, factor 7A has shown some good outcomes. But in this particular situation, AFE, both factor 7A and heparin may have some negative connotation and negative outcomes. So you likely have worse outcomes with it. So it's not recommended to use these things at this time. What are the emerging and future directions that we are looking at? Like I said early on, the biomarkers of interest, like I said early on, that we really don't have any definitive markers or diagnostic tests that will say, oh, this test is positive, therefore she has AFE. We don't know that. So there has been a lot of interest in trying to find out what biomarkers potentially, because as we talked about in the pathogenesis, in the pathophysiology, that this is essentially a immunological cascade that happens. There is mast cell degranulation, there is complement C5a, activation of the C5, C3. And so there's estrase, C1 estrase changes. So all of those things happen. So the research scientists have been looking at these biomarkers which say, okay, let's look at the C1 estrase inhibitor, the brain natriuretic peptide, which is BNP, STN, zinc coproporphyrin 1, the pro-opiomelanocortin. So these are all different biomarkers that are being studied along with, I'm just giving you like 4 or 5 out of a possible, there's like 14 or 15 different markers that are being studied for this particular thing. What are some of the non-standard treatments that have been tried in isolated case reports? And these have been tried successfully in isolated. There has not been any trial that has shown them to be, universally successful, but these are available. So if you have the ability to do any of those, then obviously, by all means, in a last-ditch effort, you can try those. You can try an antithrombin concentrate. High-dose steroids have been postulated as a potential therapy. Synthetic C1 estrase inhibitors have been postulated. Plasma exchange transfusion, and you can imagine, plasma exchange transfusion would potentially work by cleaning out those mediators that are worsening the immunological cascade, and hemofiltration. So these are some of the emerging and future directions in this. And I believe these are the references, and I think we are at an hour.
Thank you so much, Dr. Meghna. Hello.
Hello.
Yes, please.
Yeah. Thank you so much, Dr. Shah, for that elaborate talk on amniotic fluid embolism. I'm thinking we don't have enough time for additional questions.
Yes, absolutely. I mean, I'm open to questions. I don't mind, but certainly a lot of the material is on the slides themselves. So, obviously everybody is welcome to look at them, and that would be it. So, yeah.
Right. I would request our HOD is online as well, Dr. Hari Shegde. Sir, can you hear me?
Yes, Meghna, I am online.
Yes, sir.
Hello.
Dr. Hari Shegde is online.
Yeah, I can hear you.
Yeah, so I would request you to give your thoughts in the end.
Yeah, it was a nice presentation. The problem is for all the advanced investigations which are needed in an emergency, we don't have in our setup. That's the main drawback, and the blood constituents, whichever is needed for managing amniotic fluid embolism successfully, we find it difficult to get from our blood bank. Suppose you ask for a pack cell, it would take at least half an hour to 1 hour for the product or the blood, fresh blood or pack cell to reach the operation theater or the labor theater. That's why we find it very difficult. And one case where a lady, after normal delivery, I think it is amniotic fluid embolism. Then immediately we gave fresh blood. Nothing was available in that setup, and it was more than 10-15 years back. And she recovered. She went back home with her child. Both were alive after normal delivery. And we gave fresh blood. Nothing was available. We made the donors, we made the patient party, the attenders to donate the blood, and we gave the fresh blood. And it could save both the mother and the baby after normal delivery. Only one experience I have in all these years. Thank you very much, Dr. Yunus, for nice presentation.
Absolutely, my pleasure. Yeah, and if you don't have access to any of those things, obviously whatever you have access to, like, you were thinking on your feet, you had fresh blood available, so that's what you use. And the key is you don't want to wait for fancy stuff to resuscitate the mom. Whatever you have available, if you have uncross-matched blood available, then that's what you use.
Yeah, it was a dramatic recovery, and which was fine. The lady was going down, the mother was going down when we gave the fresh blood. It was a miracle, which I cannot forget. And only fresh blood we had, nothing else, and that could save her.
I'm curious. I mean, if and obviously, I've practiced in Delhi for a while, before I came to US, and so I know that the blood situation is kind of at least at that time in the 80s, or I'm sorry, in the late 90s, it was somewhat dire. But I'm surprised that there has not been much change on that front. So I'm curious, is there any chance that you can set up these protocols ahead of time and say, okay, this is a protocol that we're going to call the blood bank and say, okay, when we say massive hemorrhage stage 2 or stage 3, we want you to, what can we have available? In other words, you talk to them beforehand, what could be available at a moment's notice? What can you give us so that, valuable time is not wasted at that particular time? So I'm curious if something like that might be helpful. And I don't know, obviously, whether it would be possible or not, but if it is, it might be something to, it might be something worth investigating.
Certainly, we can give it a try, sir. We should talk to the blood bank people personally. That's what I feel. We should not send our postgraduates or somebody else. We should talk to them personally and request for whatever we need. No, that would help us. I think that's what I feel.
Yeah, I agree. And if there's already a protocol in place beforehand, in other words, they know that when you say a stage 3, okay, we know this situation is bad. We need to get on it right away. So that might be something to help.
Yeah, we can involve the blood bank people to our seminars or whatever. Then they should feel the importance of the blood being given in time and like in a shortest possible time in our setup. No,
Exactly.
That would help us. Thank you very much, sir. Thank you very much.
Absolutely, my pleasure. Absolutely.
I'd like to thank Dr. Ibrahim for arranging for the talk, and also all of you PGs and other anesthetists and obstetricians who've been a part of this 1-hour talk. Dr. Shah, thank you so much again, and we would like to hear more from you about how you manage other obstetric emergencies. We will get back to you on a few more topics if that's all right.
I would be glad to. That's absolutely no problem at all.
Okay, sir. Thank you so much, sir. Thank you, Dr. Ibrahim.
Yeah,
Indeed.
thank you, Dr. Yunus. It has been a great pleasure listening to you. So nice of you. Wonderful presentation. If you could send our presentation, I could pass on to the Department of Obstetrics and Department of Anesthesiology.
Yes, I will email you this.
Send it to me. Yeah, I'll send it to them. Where some of the some people did not watch the presentation nicely because they were probably watching on mobile, but everybody listened nicely. I got the feedback. Everybody had wonderful feedback. Thank you so much and stay blessed.
Okay.
Good day to you and good night to the people over here. Thanks to the technology that made day and night. Thank you so much. Thank you very much.
Okay.
Thank you. Good night.
Good night.
Bye-bye.